share your screen and begin your
Good
presentation.
evening, everybody. Thank you, Leslie. Thank you so much. And thank you, Jade, for being here with us. Everybody, thanks for joining us. I had a lot of questions over the past few weeks with my patients about what is the condition that most confuses them in terms of when to seek treatment or when it's bad. And so I think most of them said cervical myelopathy or neck pain that leads to dysfunction was the one that they wanted to know more about. And so Jade and I put this talk together. You know, it's a very brief overview. By no means is supposed to include all the details of what the disease process entails and what the treatment forms are. But hopefully for anyone out there that is suffering from pain or dysfunction coming from their neck, they can recognize some of the symptoms and come to see one of the providers in our system so that they can get treated and they can get relief. So I'm going to share my screen here so we can start. It's a very short talk. A lot of the time I'd like to answer your questions because that's what many people are here for, but let me share this. All right. So I'm going to start by saying that. So what is myelopathy? So a lot of patients are confused as to what it means to have cervical radiculopathy or cervical myelopathy. And, you know, myelopathy literally is a pain in the neck, not only because it originates from pain in the neck, but it's because it's very difficult to recognize, particularly very early in the process. So how can we explain neck pain leading to function? Because myelopathy more than pain is function. Radiculopathy is more pain. And that's because, you know, all the nerves and fibers from your brain form the spinal cord and go down the center of your spinal canal. And, you know, it sends nerves and branches to your arms, your legs, and the rest of your body. Those nerves are bundled in the spinal cord. And as they reach the cervical spine, the bones in the spine, they send the branches out that go to your hands, your arms, and then the rest of your body. As we age, degenerative process lead to compression of those nerves that are going out, leading to pain, which is radiculopathy, or when there is compression in the midline, in the bundle, the spinal cord, leading to dysfunction, that's what we call cervical myelopathy. And I'm showing here some anatomic figures. On the left, you see it from the front. In the middle, you see it underneath, and you can see at the bottom there how I'm not sure if you can see my arrow, but right there's the spinal cord, and you can see how you can get compressed if there's degeneration of the bones. And this is all along this length, which we can see on the left here in the midline. And then this is from the side, you can see the tunnels where the nerves come out and they can get compressed by degeneration of the bones and the disc. And we'll go into more detail in a minute. In this case, so how do we call this disease process? We call it cervical spondylotic myelopathy. And how so? Cervical is your cervical spine, it's your neck. And spondylotic is just a fancy way of saying degenerative or arthritic changes with time, not necessarily inflammatory. Some people out there may have something called rheumatoid arthritis or ankylosing spondylitis. Those are inflammatory conditions. This is more degenerative in process, and it has very little to do with inflammation. And myelopathy, which is dysfunction of the spinal cord. So it's chronic because it takes time to develop and get to a level that is recognizable. It's progressive because it's slowly over time. It doesn't come and go. It stays there and it gets worse over time. And then you lead to a decline in function because you're compressing the spinal cord in the center. And all this is secondary to degeneration of the disc, the intervertebral disc between the bones, and the bones themselves develop osteophytes and sharp edges that can lead to compression. Most of the literature out there, publications say that the mean age of onset is about 56 years old, but I've seen a wide spectrum. I see patients that come into my office in their mid 30s, early 40s with significantly advanced disease. And I've seen patients that come to my office in their, late 80s with some disease. So it's a big spectrum. I have two pictures here. These are images from Wiki Commons. It's an open source images. These are none of my patients. And so you see the bones on the large image, and you can see how the spikes of bone are forming and they form a beak. And you can see it here as I enlarged it, you see the narrowing of the disc space and the spikes or beaks. And that just tells me that there's arthritis and disc degeneration. As this process gets worse, that's when you start developing myelopathy or radiculopathy or both. So what What exactly leads to compression? Well, it's degeneration, and there's many ways that it can degenerate. So in the image at the top, you can see the degeneration of the disc that leads to herniation of some of the soft component of the disc out into the center of the canal. And you can see how it's compressing the spinal cord, the yellow area. On the bottom left image, you can see on the left side how the bones are nice and non-degenerated. You see the disc space is glistening and white. And on the right side, you can see how over time there's degeneration of not only the disc, which has significantly collapsed, but also of the bone. You can see the spikes and the serrated edges of the bone, how they widen and they create something we call an hourglass deformity. You see the edges become a lot sharper and wider, and that leads to compression. Not to mention the nerves that innervate the bone and the disc itself get degenerated, and they themselves get inflamed, and that can also lead to pain. And on the right side, you can see how when you get those bone spurs from the vertebral body, from the bone in the front or the back, as those bone spurs, that arthritis, when it grows, it leads to compression of the nerve roots, and that's what leads to radiculopathy, which is mostly pain, not necessarily dysfunction. But you can also see in the midline osteophytes, which are the spurs that are also compressing the midline. So it can happen in both ways. So why does this happen? Well, it's many things. Most of the degeneration happens with aging, right? As we get older, the tissues are less able to self-renew, and you start forming arthritis. Many of you may have had knee arthritis or hand arthritis, and there's surgeries for that as well. But when you're aging, when there's aging, there's degeneration and erosion of the bone and the disc, and that leads to some compression. Or stenosis, which is how we call it in surgery and medicine. There's also lifestyle. Many of us are working in our computers with with our necks in very difficult positions. Some of us surgeons also develop this type of disease when you're looking down in the operating table. A lot of it has to do with genetics if your family members had it in the past. But lifestyle is a big problem these days. I'm seeing more and more often younger and younger patients, and you can recognize some of your children or even grandchildren, how they're positioning their necks looking at their phones. And just tilting your neck very little leads to an increase in the weight that your cervical spine and the disc in your spine are feeling from the weight of your head. So if you're standing up straight, it's 10 to 12 pounds. Well, by the time you're at 60 degrees, those tissues are feeling 60 pounds of force pulling them down. So the more we look at our phones, the more the higher chance that we have of progressing our disease significantly. And so how can we recognize it? And this is a very important one. This is, if you guys can take anything out of my talk today, this is the important side, because the problem with cervical myelopathy is that it develops in a stepwise fashion. Most patients develop very mild symptoms at the beginning, and then as the symptoms progress, you don't really notice any deficits until you have a big step down. You notice some changes, and then you stay at that level for a while before you decrease more. So it's really hard to recognize until you reach a level where the dysfunction is significant. So what is the most important thing to do is, what you want to do is, as soon as you start having some questions that, well, I have some neck pain, some numbness and tingling in my hands, I need to see somebody, that the most important thing they have to do is get a thorough history. Again, get the timing of your symptoms. When did they start and how did they develop? If there was any trauma, some people may have had car accidents, or they fell at work, or they fell from a ladder, or a slip and fall, and that can lead to some injury that can lead to exacerbation of the disease process. Or they start complaining, I have trouble writing. I can't coordinate with my hands. So it's difficult to button my shirt. Some men sometimes say it's difficult to shave. Women say it's difficult to put my makeup on, and activities that you used to be really good at, now it's hard to control your hands, and that's a sign that you probably should see somebody about. Balance as well, getting dressed or opening doors, you don't feel as steady on your feet as you used to. Again, you start to feel numbness and tingling in your hands, coming down of your neck, and in certain areas of your arms. That's important to know. Issues with bowel or bladder, when the compression gets really significant, you may have incontinence or bowel or bladder. That usually becomes very evident late in the disease. So few people present like that, but that's something to note. Or when you're moving your neck up and down, you feel electrical shock like pain shooting down your spine. That's something we call Lhermitte's sign. And that's something that should also prompt you to at least see a professional. It may be nothing, but it may be something to look into. Now, something that I wanted to point out is that most of our studies show that only less than 30% of people with this condition experience actual pain in their neck or their arms. Most of it is functional decline, particularly when the compression is in the midline. And so just because you don't have pain and have dysfunction doesn't mean that something's not wrong. If you do have that progression, which is slightly hard to detect, then maybe it's time to see somebody that they can get X-ray, an MRI, or some physical examination that can help them diagnose you and treat you promptly. What about a physical exam? What do we do in a physical exam? Well, you know, once you see a patient that has some issues with balance, with a hand dexterity, then we start doing an exam and we say, well, what parts of your arms and legs can you feel? And we use a sensory exam to see if there's a distribution of the nerves that come from your neck where you're not feeling as well as in others. I have a dermatome map on the right side, and I actually have a map like this in every single one of my diagnostic rooms where I see patients, so that they can pinpoint with their hands where are the regions where they feel less normal and compared to before to prior. And then, you know, based on that, you know what part of the neck is the one that's getting compressed. So it's loss of sensation in central regions of your body. Some weakness in the same distributions, those same nerves that innervate the sensory part of your skin also innervate the muscles for function. So if you have weakness or difficulty with motion in certain muscles, that also gives me a sign of where your compression might be. Once the compression gets very brisk, you start having difficulty with reflexes. You have something called hyperreflexia. So instead of being a normal jerk, it's a significant jerk. And that basically means that the neurons in your spinal cord are hypersensitive or sensitized to motion because they're being compressed. There's also, we actually make our patients walk in a straight line and, you know, putting heel to toe in front of each other. And if you have difficulty with that and difficulty with balance, that also tells us that you may have some signs of myelopathy. That part, it's part of the stiffness in the gait. It's not a fluid gait. And the last one is much more less precise, but it's the classic sign that many physicians, spine or non-spine doctors use, is the Hoffman sign. And I actually have one of my colleagues, I was able to film him and pretending to do one. And let me see if this is going to work. There you go. And you see, as you flick the middle finger, there's involuntary flexion of your finger. So as we flick the middle finger, the thumb or the index finger tend to jerk backwards without the patient wanting to do so. And that also sounds like an hypersensitivity of the nerves and hyperreflexive nature of this disease process. So then how do we evaluate it? After we reach the conclusion that, okay, there's probably some arthritic changes, some degeneration of your neck, we get x-rays. And, you know, it's always easy to start with x-rays just in case you see something that may be of a different nature. We have a view from the front on the left, which is an AP view, and that is mostly to look at the alignment of the spine, make sure that somebody wasn't born with scoliosis or had another disease process going on, or if there's a fracture or a dislocation, misplacement of the joints. And then we switch to lateral views, which give us most of the information. In that case, we want to see a nice curvature of the spine. It's like a C or a reverse C, depending on how they take the x-ray. Then we look at the disc spaces. The marshmallow looking things are your bones, and the darker areas are your disc spaces. That tells us the alignment of the spine and the space of the disc. And here, this is the similar one that we saw earlier. There's some arthritic changes in the front that show some arthritis. And if you can compare the bottom disc and the above disc to this one in the middle, this is the one that's mostly collapsed and has arthritic changes. After we see that, if we see any osteophytes, which are the spurs, or if we see any slippage of one vertebra of the other, we call spondylolisthesis. We also get flexion extension x-rays. When you come to our office, we do all four at once, so we don't have to repeat them. And then here we see if any of the vertebral bodies slip more than another, if there's an exacerbation of the features of the arthritis, or if there's any other area that we should focus on with advanced imaging. And that just tells us if there's any instability in the motion of your neck. Once we get this, and another form of evaluating the soft tissues, in this case, like in x-rays, it's mostly just the bone, the hard tissue, not the soft tissues. So when the time comes, if the course of the treatment necessitates it, we get an MRI. And the MRI is really the gold standard of these days of treatment, of diagnosing, where you get imaging of the soft tissues in your body. And in this case, you can see the bony architecture as well, but mostly you only see the soft tissues very well. And in this case, we can see this is also a generic patient, is none of my patients. And you can see the marshmallow looking things are your bones, and the dark spaces are the disc. This patient has more advanced disease. You can see that their neck is shaped like an S. It goes backwards and then frontwards again. And in this case, you can see those osteophytes in the bone, but they're not as well defined as in the x-ray. In this case, what we can see very well is the disc is bulging in the back. You can see how there's some disc protrusions, not necessarily herniations, but protrusions, and how they're compressing the midline and the cord. And we're starting to see some changes even within the anatomy of the cord. It doesn't look nice and dark. It's starting to look white, and that just means that there's been compression for a long period of time. This is looking at a person from this side, front and back and top and bottom. And this one on the right side, it's an axial view of the MRI where the patient is laying in the bed. They're sliced like a loaf of bread. And then the feet are coming out of the screen. The head is on the other side. And then we see the left and the right. And in that case, you can see how the spinal cord in the middle is getting compressed by this piece of disc that's compressing, and that's leading to decreased space in the cord. And that's what we call compression, is stenosis. This patient will have something called cervical stenosis, possibly from a disc herniation. Again, this is not my patient, but I wanted to show you in general how an MRI of your cervical spine looks. This is another image. There was a study that they did in animals, and in this one, I wanted just to highlight how it is important to get an MRI, because in this case, you can see the changes in the signal intensity of the spinal cord itself. So you can see the spinal cord here, and you can see here, you can have compression, which is less chronic, more like short term, and you see no changes in the signal of the spinal cord. When it's chronic and the compression has been long-standing, you see that the inside of the spinal cord is getting wide. So that means that there's more degeneration of the cells within the spinal cord. That's death of the cells within the spinal cord. And that's something that we need to take more serious. This signals to me that there's a more advanced disease process that may need prompter attention. What other modalities do we have? Well, in certain instances, some patients can't get an MRI. There may be some of the other where either you have a pacemaker and it's not MRI compatible, or you had a previous surgery and you have metal in there that we can't really do an MRI with, or your bones have become so calcified and arthritic that we need a CT scan to see a more detailed anatomy of the bones. Think of a CT scan as an X-ray on steroids. It's an X-ray type of imaging, but it is much more detailed and fine, so we can see much more anatomy and more in 3 dimensions. This is just an example of a CT scan where you can see again like an X-ray, but the resolution is more significant. And if we still have difficulty in diagnosis, if we don't know, okay, we know you have some neck compression, but the pain or numbness and tingling in your hands are not concordant with the imaging we see, we sometimes send you to get an EMG, and that's a study in which they put needles in the muscles in your arms and in the distributions of the nerves, and then they send electrical signals to try to see where the compression is, and they can see if the compression is at the wrist, at the elbow, the shoulder, and in your neck. And that way, maybe you don't need, I can find out, okay, well, this person doesn't need neck surgery. They actually have carpal tunnel, and that's why they have numbness and tingling in their hands. And I can see you to see one of my my hand colleagues at Rothman that can take care of that as well. So we have definitely different tools that can help us diagnose and treat you adequately. Now, how do we treat it? Well, that's the big question. Once you have it, how do we get rid of it? Well, unfortunately, there's no really way to get rid of cervical myelopathy. It's like arthritis. Once it starts and you start developing degeneration, we cannot lead to regressive regeneration. Unfortunately, we're not there yet. So we can only ameliorate the symptoms or prevent them from getting worse. Many of you have very mild symptoms, or you only have the radiculopathy that's compressing the roots, the nerve roots. In that case, we can treat you with anti-inflammatories. Some patients already take Advil, Aleve, Motrin, ibuprofen, and those are generally prescribed by your primary care doctor over the counter. Now, be careful, because people with heart disease, kidney disease, or bleeding disorders, or stomach upsets may not tolerate these medications that well. So always make that decision with a healthcare professional. My first line of treatment in my practice, we try to send everybody to physical therapy, because believe it or not, as we count our patients, about 80 to 85% of them get better only with physical therapy. At times with some anti-inflammatory treatments during therapy, it helps to prevent the pain from not allowing you to complete the therapy successfully. There's other forms of medications that we prescribe, nerve modulators, gabapentin, Lyrica, or tricyclic antidepressants. They also have some nerve modulation features that allow us to treat some pain. We generally don't do narcotics anymore. That is, we leave that for the pain specialist, and it's really fallen out of favor due to the crisis that we're living in our country. So thankfully, most of our patients are doing very well with these other therapies, and we avoid sending a pain specialist. But that's an option if we reach that point. Once we need to reach the next step where the physical therapy hasn't been enough, one of the things that we can use are epidural steroid injections that I send you to one of my partners in Rothman. They do a steroid injection at the base of your neck. The steroid leads to an anti-inflammatory response. All the angry nerves get calmed down, and you can continue to do therapy. And sometimes that's all you need. All you need is to calm the nerves from being inflamed from the compression. You do some therapy that strengthens your core, strengthens your muscles. That leads to a better positioning of your neck. And as you position your neck better, the nerves get decompressed, and then your symptoms improve. And that usually when there's mild disease, that's when we can do away with this. Sometimes we can prescribe a collar so that you don't move your neck as much, and that helps. And at the end of the day, lifestyle modifications is a big deal. You know, if you're using your phone, try avoid using your phone that way. Or we tell patients to try to use it above, or do if you're at work, try to do a standing desk to position your neck better, and that usually helps some of your symptoms. But at the end of the day, the disease progresses or the pain relief is not significant or the functional recovery is not significant, then we got to move to operative interventions. And I'm going to talk about the basic ones that we do. There's, I'll mention the additional surgeries that we can do based on your degree of disease and symptoms. But the gold standard here is what we call anterior cervical discectomy and fusion. Sorry. Once you reach a point where physical therapy and injections are not good, and your MRI reaches a level of compression that concerns us, that you reach a level of deficit that if we let it to continue growing, it's not going to allow you to either get better or it's going to lead to more damage. We want to decompress so that we at least get you at that level. We can't promise you that you'll recover, but at least you won't get worse. Many patients up to 70% recover function, but some patients stay at that decline. So once you start progressing, it's important to come and talk to us because we may be able to intervene sooner rather than later, so you keep more function that you will otherwise have. And so how do? We approach the neck from the front. We move your tissues to the side, and it's a very easy approach to the neck. We remove the osteophytes, the spikes, and the spurs, and we take away the arthritic disc. And we put either an allograft, a piece of bone from a cadaver, or we put on a polymer cage, and that allows us to lead to fusion of that bone. The bone becomes one, and we put a metal plate in the front that allows it to stay in place. And you have some loss of mobility, not significant, but then you don't have the mobility and the compression that's leading to functional decline and pain. We can do it in one level or in multiple levels. And there's the different risks and benefits, and depending on the type of disease that you have, we would have to discuss what the option is best for you. Another option for, in general, younger patients with mild disease is doing a cervical disc replacement. And in that case, you do keep some of the flexibility in your neck that a fusion would take away. Not much, but it's there, and it technically spares some of the other levels that are still flexible from feeling the stiffness of the fusion construct if you get the fusion surgery. But we don't have long-term outcomes. Some of the studies that we're getting right now are only 5, 7, maybe 10 years out. So we don't know what would happen to this disc in 15, 20 years. And if some of you keep it for 20 years and it fails, well, then the revision surgery to take it out and fuse it may not be as easy as it would have been if we had fused you in the beginning. So that's also another discussion that we can have based on what your needs are and what your disease process looks like. Now, in some older patients, we're going through the front is not ideal, or they had surgery before. We go through the back, and in that case, what we can do is open the back of your neck and decompress the spine by removing the pieces of bone that are pushing it inwards. And the studies have shown that it's equally successful. It's a little more painful because the tissues back here are much more sensitive. But at the end of the day, if it's the function that is deteriorating, then we want to prevent you from losing too much of it. And so that's the option that we have. There's a more milder procedure than a fusion where we do a laminoplasty, where instead of taking the bone away, we just wing it open to give more space and put the metal similar to this. But that is limited to certain patients, just like the cervical disc is less invasive, but it depends on what type of curvature you have of your neck and what the compression level is to see if it actually will lead to some equivalent results. And that's it. I wanted to talk to you a little bit about how the disease presents, how we find out about it and detect it and diagnose it, and then how we treat it. The most important thing is that there is options for relief of pain and improvement of function. Keys are to recognize your symptoms. Once you realize that something is not as it should be, you see a healthcare professional to get a prompt diagnosis, and then we'll get you on your path to improvement. We can do operative or non-operative conservative management, whatever you need, we're able to treat you. So thank you so much.
That was wonderful. Thank you, Dr. Canseco. We did have a few questions that came through, so if you don't mind, I'm going to read them off to you. Oh, Jade, I see Jade's already answering some. Sorry. Jade, go ahead. Why don't you answer that one then? Read Todd's question and answer that if you don't mind.
Sure. Todd, I'm hoping that he's okay with me sharing, but so Todd asked, can a compression in the cervical spine cause tightness in the arm and make the thumb and pointer fingers curl in? My response is, Todd, thank you for sharing your question. Sorry to hear that you're having some pain in your arm and tightness. So pain in the arm and muscle spasms certainly can be related to cervical spine issues. However, there are many other causes of your symptoms and arm pain and constriction. And in order to kind of figure out and parse where the sources of your symptoms, you would need to have a complete history and physical by a physician or provider to kind of get to the root of what's going on.
Dr. Canseco, is there anything you wanted to add to that?
Yeah, no, that's perfect. Yes, Todd, so it could be, but like Jade said, there's a lot more that comes to it. There can be some weakness and some pain and some dysfunction, but we would have to do a full physical exam to make sure that that's where it's coming from, or to send you to the right person to treat what you have. But yeah, that's correct.
Great. Another question that came through from Zelda said, what happens with the nerve in the area of the graft?
Well, so that's a very good question. So if we come from the front, we never go deep enough to touch the nerve. We take the disc space and part of the bony architecture that's blocking our path, and then we put the graft, and that stays in the front. The nerve is behind it, and the nerve roots are coming out behind the graft, so it doesn't touch it. So the graft doesn't lead to any compression or impingement on the nerve roots if you place it carefully. But yeah, it's not in the region of where that would be.
Thank you. Looks like a question did start to come through, but it's incomplete, so I really don't have the actual question, but it was from a patient that had previously had a surgical fusion done in 2013. Looks like maybe she lost some use in her arm, but no pain. But today, maybe she's having a new issue, and I think we're missing the second part of that message.
I think it's at the bottom. I think
Okay,
it's at the bottom.
There we go. All right. Today, she's in extreme pain that is now going down her right arm. Will I lose complete loss of my arms, and can my pain be resolved?
Well, I mean, hopefully not. I mean, I think, Sandra, you're one of those patients that I would love to see sooner than later in our office so we can get imaging done, do an exam. And the hope is that we see you and we address these issues promptly so that you don't have complete loss of your arm. I didn't treat you before, so I don't know what they did in your neck. But yeah, the hope is that we can relieve your pain and at least improve your function as best as we can. So if you can give us a call and make an appointment, we'd be happy to see you.
Another question that came in said, I had significant neck problems from car accidents and a fall in my 50s, but with physical therapy and compressions, I recovered. However, I am diagnosed with cervical stenosis. Presently, I am achy, but feel better with exercises. Am I a candidate for myelopathy?
Well, so I think you mean if you're a candidate for surgery. I mean, that could be the possibility. I think if physical therapy and compressions help you recover and your symptoms are not severe, I don't think you need surgery yet, or maybe you won't need surgery. But if you have cervical stenosis, that just means that you have had compression in your neck either for a while, and the therapy helped you relieve. The therapy won't get rid of the stenosis, but it'll help you improve your function. I think if you feel really well, what you could do is come see us. We'll get an X-ray, we do an exam, and we tell you what degree of stenosis you have, and if what you're doing right now is enough, or if we need to do more. I think it doesn't sound like you have cervical myelopathy at this time because you say that your function is really well, but it's something that we can definitely look into if you're interested in coming to see us.
Another question that came in, what is C5 palsy?
C5 palsy, that's a good question. And that's, it is related and unrelated to this topic. C5 palsy is when there's a dysfunction. It's like, I don't know if you guys have seen after Lyme disease, some patients get dysfunction of the facial nerve palsy. Well, it's just dysfunction of the C5 nerve. And that can happen for many reasons. The reason I believe Martin is bringing it up here is because in some cases, when you do an anterior cervical discectomy and fusion, or even posterior cervical discectomy and fusion, when you're doing the C5-6 or the C4-5 area, some patients, very few of them wake up with some dysfunction of the C5 nerve. Now, most of them recover. Very few of them have permanent damage, but it is something that happens very rarely. And that just has to do with the type of surgery you're performing, how and who is performing the surgery, and how close you get to the nerve root. So if you're careful, it's rare for it to happen. But the good news is that if it is something that does happen to you, at least in my experience at Rothman over this past few years, every single one of our patients recovers function. But it is a good question. It's one of the risks that we go over when we're planning the surgery and we do consent. We do tell you of what its C5 palsy is, what the risk of it is, and what we do after it, if it happens for recovery.
All right. Thank you so much. It doesn't look like we have any other questions that have come through at this time, but if anyone is interested in learning more about Dr. Canseco or to schedule an appointment with himself or with another physician here at Rothman, you can do so by calling us. It's 800-321-9999. You can also visit our website, rothmanortho.com. On each individual provider's bio page, there is an option to click and request to make an appointment with that provider, or just at our website at the very top, there is a blue box that also says book an appointment, and that will lead you through different methods to do so. So again, thank you, Dr. Canseco. Thank you, Jade. And thank you everyone for joining us this evening. We will be sending a recording of the lecture to your email. Thank you.
Thank you guys. Have a good night.
Thank you, everyone.